thank you.
Yeah, I might pronounce correctly.
That's fine. Good morning, and thank you for the opportunity to present our study findings and also for the Travel Award kindly provided by ICS. The IMPAQTS study is an exploration of incontinence associated with multiple sclerosis and its impact on quality of life. It is funded by the MS Society in the UK and is born out of the lack of literature in this particular disease area regarding urinary and anal incontinence. Where studies have been conducted, they tend to focus on urinary incontinence in isolation and predominantly in women, and depending on the measurement tools used and the definitions employed, prevalence estimates differ quite widely. For the purpose of this study, the ICF definitions have been adopted. Recruitment was undertaken across 8 UK neurology centres and also self-referral via the MS Society website between June 2014 and December 2015. Full ethical approval was granted and inclusion criteria were defined as a diagnosis of progressive multiple sclerosis. This decision was taken to avoid the transient symptoms that may exist with a relapsing remitting diagnosis. Individuals had to have a self-reported symptoms of urinary and or anal incontinence and the ability to complete questionnaires. A raft of 6 validated questionnaires were administered by post to participants over a 4-week period to address the various areas of interest for the study purposes. 200 individuals were recruited at a ratio of about 3 females to 1 male, and the age range sampled was wide, suggesting a representation of the population of interest. Completion rates were high, which is encouraging for postal questionnaires. For some of the sexual matters items, this dipped to 81%, which is still high given the sensitive nature of this area, but aside from the sexual matters, it was 87% plus. 2 questionnaires were included to evaluate a generic and MS-specific health status to give us an idea of the disease severity of the population. And using the EQ5D, which is a generic measure of health status, we observed scores between the range of 8 and 95 out of a possible 0 to 100. And with the functional assessment of MS score, we observed scores ranging 25 to 165 out of 0 to 176. So we considered that we had sampled quite a broad range of disease severity and therefore didn't consider this to be a skewed population towards a particularly poorly or particularly well population. For the following graphs, the figures are intended to represent the population, with red figures indicating those who reported symptoms and blue those who didn't. Initially, we looked at any level of symptoms, regardless of frequency or severity, and found that 92% reported urinary incontinence and 97% reported anal incontinence. Now, we should revisit at this point that this is a self-selected sample of individuals who had identified themselves with incontinence symptoms, so levels are going to be high. But perhaps what is surprising is that anal incontinence was reported by more participants than urinary incontinence. According to the ICS definitions, with the exclusion of flatus incontinence, using the fecal incontinence definition, this dropped to 79%. Looking at incontinence in isolation, so those who are experiencing only urinary incontinence, this was 3%, and those only experiencing anal incontinence was 8%. So in combination, essentially 81% of participants experienced urinary and anal incontinence, and with the exclusion of flatus incontinence, this dropped to 64%. So we know that this sample experienced incontinence. We wanted to delve into that a little bit deeper and find out how often these symptoms were happening, as they could be very rare. So frequent symptoms were defined as those that occurred daily, often, or all of the time, according to the response frames within the questionnaires used. And we found that urinary and flatus incontinence occurred in over 50% of the population frequently. And this dropped to 42 and 31% respectively, looking at liquid stool and solid stool incontinence individually. We then decided to look at the differences by gender and found that for bowel symptoms, these were fairly equal, but there was a more marked difference between the reports of urinary incontinence, with a 12% increase for females. So we know that men and women are, relatively speaking, experiencing symptoms at a high level frequently, but how severe are these symptoms? And the urinary incontinence questionnaire allows for a self-perceived report of severity, and we found that 82% reported their symptoms to be at the moderate or severe level. We looked at associations between urinary incontinence severity and the frequency of anal incontinence and found that as urinary incontinence severity increased, the frequency of anal incontinence increased. However, we found no association between the functional assessment of MS score and the incontinence score, suggesting that regardless of MS disease severity, there was no relationship to the level of incontinence or reported incontinence. So looking at the impact on quality of life, high impact was defined as those individuals reporting a lot, and found that in terms of urinary incontinence, a third of the population approximately reported problems with their physical activities and ability to travel. This doesn't mean that the other 70% were not experiencing this issue, it's just that they hadn't reported it a lot, so various gradations down. This was just the high end of the spectrum. In terms of anal incontinence, approximately 2/5 reported the issue of always needing to know where toilets are, and their bowels causing them to feel embarrassed in 21%. With regard to sexual activities, urinary incontinence posed more of a problem than anal incontinence, with approximately 2/5 of males reporting a lot of impact caused by the urinary incontinence and only 1/5 of females. But there's relatively little impact caused by the anal incontinence symptoms, although these participants were fewer in number. So what has our study shown? We were able to sample a broad health spectrum of individuals with progressive multiple sclerosis and found that urinary and anal incontinence rarely occurs in isolation. We also found that higher levels of anal incontinence occur in this population, with flatus incontinence being most responsible for these symptoms. So incontinence is occurring a lot, frequently, and relatively severely. And that we know that increased severity of urinary incontinence is associated with an increased frequency of anal incontinence, and both of these symptoms pose an impact on quality of life for approximately a third of the population at the highest end of severity. So our conclusions from the study are that urinary and anal incontinence occur frequently in combination in men and women with progressive MS, and that the severity of their MS is not related to the degree of incontinence. So for clinical practice, that means that if an individual is presenting with one or the other symptoms, we need to be asking and proactively inquiring about the existence of other symptoms, and also potentially challenging common assumptions in regard to gender. Men are experiencing this in relatively high levels in comparison to women, and also that it is not related to disease status. So just because somebody is relatively well with their MS does not mean that they will not be experiencing these symptoms. For research, it is an opportunity to identify the need to conduct studies in both urinary and anal incontinence in combination, and also addressing, evaluating men and women in combination. And key to the findings of this study are that accurate identification and appropriate treatment are absolutely necessary to signpost people to treatments and minimise impact on everyday life. Thank you.
Thank you. Nice presentation. So any question from audience? Please.
Really enjoyed that. I thought that was a great.
Could you mention your name, please?
Presentation. I'd like to emphasize that, as I understand, these findings are limited only to the subgroup that has progressive MS.
Yes, primary and secondary progressive MS.
Yeah, primary or secondary progressive. So that's certainly a message that needs to reach the neurology and general medicine community, because I don't think most of those patients are getting referred. Maybe they don't need to see urologists, but they certainly need almost automatically to be seeing a continence advisor or someone to be dealing with this, because this isn't, I mean, it's almost a guarantee that they have one of these problems. It's an amazing prevalence that you've discovered.
Absolutely. Thank you for your comments. We have submitted to Neurology Congress as well, and do intend to bring this to the wider audience of the individuals who can actually influence treatment for these individuals.
Okay, any other questions? Maybe I missed one point. So what kind of treatment? So as you mentioned, the treatment is necessary for that increase in the quality of life, but what kind of, your patient have any treatment for that stop or decrease the anal or urinary incontinence in this population too? So then this type of medication, or responders, non-responders, may affect this type of the quality of life assessment.
Thank you. Treatments, again, vary, and the successes vary as well. And my particular focus is on looking at self-help, and as was mentioned yesterday in a number of the committees, in terms of sort of group programs, pelvic floor muscle training, self-help for these individuals is certainly an area of further research that I'm furthering. But essentially, yes, there are the same treatments that are available for individuals. They're quite a motivated group, so in terms of self-help being an avenue for improving their outcomes, it certainly is an area that is ready for research.
Can I ask you another question? You have stated that you have not noticed a relationship between severity of MS and the presence of incontinence, of both types of incontinence. Is this right?
Yes.
Right. How have you measured the severity of the MS? Because I haven't seen in the abstract really any measurement of severity of the MS, like the expanded disability status scale or something like that.
Yes, so within this study we used the functional assessment of MS self-report questionnaire, which has various domains looking at symptoms.
The FAMS.
Yes.
But this is a quality of life questionnaire. This is not a severity index, actually.
No, and it does include various elements of symptom evaluation. As you say, there was no EDSS score, and it's purely for pragmatic reasons, and the nature of the study and how we're conducting it, to pull everybody in for an EDSS was not fundable or possible. So a pragmatic study. But
if I may suggest, I would add also the information of an expanded disability status scale or some functional neurological evaluation to reinforce this message that there is no association between severity of the multiple sclerosis and incontinence, because I think it's important, not just the quality of life. Quality of life is also related to the presence or absence of incontinence, by the way. So I think it's not the right way to assess this point.
Yeah, absolutely. Yes, the EDSS is the key indicator. Thank you.
Thank you.
Wendy Brown from Australia.
Sorry.
Oh, sorry.
Didn't see that.
Please.
Wendy Brown from Australia. So as I understand it, the EQ5D has a mobility question. So
Yes.
I wonder how the mobility question was associated with the levels of incontinence.
So not presented here, but essentially none of the individual domains had an association with the incontinence scores. We are going on to secondary analysis to look at things in greater detail.
It's quite intuitive that if you have difficulty with movement, you have difficulty getting to the bathroom.
Quite.
Yeah.
Thank you.
Okay. Thank you very much.